Now we move on to the final topic, that is keratoplasty, the final frontier in ectasias. I wanted to ask you, sir, what about the post-op steroids you have to give for a long time?
Post-op, you can give regular steroids, antibiotic and steroids for 1 month, and then I usually taper it to lotipred and continue for 8 more weeks. Antibiotic and steroid, like prednisolone or dexamethasone for 1 month. Initially, you can also keep the hypersol so that the hydration is better for 1 week or 10 days. You can use the hypersol so that entire water is swollen out and you get a better result.
Do you suture the wound? No, you just leave it.
No, sir, it's just like an SSCS wound. We can place a BCL and leave it. So wound suturing is not required. In cases like where we do in VKC and all, there the tunneling becomes difficult. So once we have any free flaps or something like that or cut edges, we put a suture. Otherwise, routinely suture is not required.
Thank you. Good afternoon. Thank you, Arjun, Dr. Srini, for the opportunity. So my topic is on the surgical management of keratoconus. So mainly I'm talking on DALK, deep anterior lamellar keratoplasty. We all know there has been a significant change or a paradigm shift in the management of surgical management of keratoconus. So these are some of the accepted indications for DALK in keratoplasty in keratoconus, like advanced keratoconus with poor vision with contact lens or contact lens intolerance, non-resolving eye drops or healed eye drops with poor visual acuity, and the percentage of patients undergoing keratoplasty in case of keratoconus is around 12%. And younger age with the steeper keratometry are more prone to progress fast, and these are the cases which require DALK. And patients with corneal scarring in keratoconus, this scarring could be due to the advanced nature of keratoconus itself, or it could be due to scarring because of C3R. You can have a central thick haze which can affect the vision, or scarring due to progressive melting of cornea following C3R, and infection or infective keratitis in the center causing scar can be the indication for DALK. And there are various techniques which has been described, and the most common and the easiest way of reaching the desmids is a big bubble technique described by Anwar and Teekman. And this is followed by the other common technique is layer by layer dissection technique, and there are many other techniques which are described by different authors, multiple bubble technique, or injection of saline into the stroma to separate the stromal layers, or dissection using viscoelastic substances, or you can use microkeratome or femtolaser to separate the stromal layers and then reach the desmids. So, a thorough preoperative evaluation of these patients is very important. It can be a slit lamp examination or an anterior segment OCT examination. There is a classification based on the anterior segment OCT classification. This actually classifies keratoconus into 5 stages. The stage 1 is the earliest stage where you see a thinning of the epithelium and stromal layers. No scarring, nothing, but stage 5 is panstromal scarring. That is an advanced case of keratoconus with the healed eye drops leading to panstromal scar. So this classification is important to plan your surgical technique or a surgical procedure. And this is the algorithm for performing DALK, taking advantage of the preoperative OCT up to stage 3A, 1, 2, 3A. You can safely go ahead and do a DALK, big bubble DALK. And beyond that, 3B onwards, that is 3B is actually there is a stromal thinning, but there is a scarring of the posterior stroma. This is the stage 3B, and 3B onwards, you should go ahead and do a layer by layer manual dissection to reduce the complication of perforation. And there are three types of bubbles. Like type 1 bubble is the white margin bubble. This is actually the strongest bubble. The chances of perforation with the type 1 bubble is very less as compared to type 2 or type 3 bubble. Type 2 bubble is a thin margin bubble or a clear margin bubble, which is a large bubble as compared to the type 1 bubble, and it is more prone to perforation. And type 3 is a mix of type 1 and type 2 bubble. You can have a large type 1 and a small type 2, or a large type 2 and a small type 1 bubble. I just want to show few cases. This is a video demonstration of type 1 bubble formation. It's a nice, it's a clear-cut margin it has. It's a white margin bubble, and the floor of the bubble is thick. Actually, you have descemetes and Duas layer as the floor, so that constitutes around 30 microns. Whereas type 2 bubble, it is only the Duas, it's only the descemetes layer. This is again a case of type 1 bubble. Just showing a slow motion video of the big bubble formation. I have injected a small air bubble to demonstrate. You can see the bubble, big bubble forming, and it's displacing the small bubble in the anterior chamber to the periphery. So this is a type 1 big bubble. So a few case examples. This is a young boy, 12 years old, with a visual acuity is only 6/60, is not improving with glasses, and this is the topographic picture. 271 is the thickness and high astigmatism. Patient is not improving beyond 660 with the best of correction. And I usually do a big bubble dark if there is no scar. You have seen the big bubble here. I do a superficial lamellar keratectomy and then de-roof the bubble. This is using a 11 number blade. This is a nick incision I have made, and I am injecting visco into the nick incision to keep the descemetes away from all the manipulations. And with the help of a Vanna scissor, I go ahead and excise the posterior lamellae up to the trephination margin. Once this is done, I prepare my donor tissue with the Vexel sponge. You just scrape off the or peel off the descemetes and place the donor tissue on the host bed and suture it. I usually use 16 sutures if the graft size is more than 8 millimeters, and less than that 12 sutures I put. This is not a rule. I usually follow this. Coming to type 2 big bubble, it's a large bubble. You can see the large bubble. It is a clear margin bubble. The previous one had a white margin. This is a clear margin bubble, and tends to rupture in most of the cases. Carefully you can dissect it, but most often you end up with a perforation. A case, the patient has counting finger 3 meters with the central corneal scarring, and this is the topography. And this is anti-segment OCT. You can see the highly curved cornea. It's around 70 diopters, and you have a scarring extending up to deeper layers of stroma. And these are the cases you can expect type 2 or type 3 bubble. I'm just injecting air bubble into the stroma. So in the third attempt, I could get a large big bubble. That is a type 2 bubble. So identifying this bubble is very important. So I started doing a manual layer by layer dissection. So you can go layer by layer. There are multiple small bubbles in the stroma, so that will give us a guidance. Actually, you can use it as a guide and go just short of these small bubbles. You can stay away from these bubbles and then place the donor tissue on the host bed. This is another case of healed hydrops. So you can see the anti-segment OCT picture, the scarring around the DM rupture tear, and this is the topographic picture. 70 diopters is the is the keratometry, and this is the case. Like since the DM tear is not in the center, I attempted a fake DALK. So here I am injecting air into the stroma, not to create a big bubble. It is just to create an emphysema of the cornea, and that helps me in dissection. And all these multiple bubbles, they act as a guide. We can stop dissection just short of these multiple bubbles. So once dissection is complete, you place the donor graft and suture it. This is the first day post-operative picture of the same patient. You can see a scar here. There's a tear in the desmoids. This is 6 weeks, and this is 1 year post-operative picture of the same patient. Since this scar or the tear is not in the center, the patient had a very good vision, visual acuity of best corrected visual acuity of 6 parts. This is the last video. It's an advanced case of keratoconus, the healed hydrops, and again there is a tear in the center. So I've injected air, and this air acts like a tamponade. The one advantage here is, even though the scar, the tear is such a large tear, not in the center, slightly away from the center, but usually it won't enlarge. That is because of the margins gets fibrosed over a period of time, so it won't enlarge. So in spite of having such a big tear, you can continue with the DALK. This is the post-operative picture. This is a 6 months post-operative picture, and this is 2 years post-operative picture. You can see the tear here, which is sealed very well. So we have published the outcome of deep anterior-lamellar keratoplasty with the intraoperative perforations, and most of the perforations are due to the pre-existent DM perforation, healed hydrops, and the results were good. And another indication is, as I have mentioned, this is actually post CXL infective keratitis, which has healed well with a scar, dense scar right in the center. And the BCV is poor. In such cases, you can go ahead and do a DALK. This is a case of progressive melt. Particular patient developed progressive melt. This is the thinning which is happening, and ended up with a desmetocele. And we went ahead with the keratoplasty. I tried a DALK in this case, but I could not preserve these desmoids very, very thin, and ended up with the PK. So there has been significant changes that has happened in the last couple of years in the management of keratoconus, and surgical management also has changed. Madhu has his own technique of Bowman's transplantation, many other techniques, and DALK in healed hydrops itself is a new evolving technique. So you can always do a DALK in healed hydrops if the scar is away from the visual axis. and DALK is very safe and effective in the management of indicated cases of keratoconus. Thank you very much.